Welcome to the Onco PT podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent Onco PT. Here's your host, Elise Cantu.
Hey there, Onco PT, and welcome to this episode of the Onco PT podcast. In preparation for our fastly approaching Cancer Rehab Community Conference, we are so excited to welcome our main sponsor to the podcast to talk a little bit about what they do and how they are supporting the amazing work of lymphedema therapists all across our community. So I'm so thrilled to welcome Mary Calys to the podcast today. Mary, welcome to the podcast.
Thank you, Elise. It's great to be here.
So would you mind telling us a little bit about you and then your role with Tactile Medical, who is our gold sponsor for the Cancer Rehab Community Conference 2025?
So I am a physical therapist. I'm a certified lymphedema therapist. I worked in cancer rehab for 25 years. I founded 3 cancer rehab clinics, one in a private hospital setting, one in outpatient freestanding setting, and then I did a cash-based practice. Then I came to Tactile because I really wanted to influence more people, and now I serve as a senior clinical specialist. So I travel the central United States. I provide education, consultation, any type of troubleshooting, brainstorming, problem solving that clinicians across my region need.
Mm-hmm. So starting and founding 3 oncology rehab sites is really, really tremendous. How did you get into cancer rehab in the first place?
Well, initially, when I was a young child, about 10 years old, we had a very close family friend who had breast cancer, and she had a radical mastectomy. And we went over there many days in a row to go help her learn how to get in and out of bed. She had a caregiver, but, she had a lot of needs. And during that time, her arm became extremely swollen, what I would now call stage 3. And I remember watching the whole process. And this may be shocking to you, but what do you think the treatment was for her lymphedema?
I'm kind of afraid to respond, honestly. Like, I think my first gut instinct is nothing, to be honest.
They actually amputated her arm.
Oh my God.
They did. And so where we were from when I was 10 years old to where we are now, to where we have these non-invasive surgeries, more targeted treatments, we have more CLTs, we have to still increase our knowledge of lymphedema. We have come a long way, even though there's still more work to do. But that made a very lasting impact on me. Then fast forward several years later, when I was the rehab director in a home health clinic, one of the oncology nurses asked me to go into a home with a patient who was getting chemo in the home to see if I could, quote, do some exercise with them. So I went to the door and rang the doorbell and waited almost 20 minutes. I could hear them coming to the door. It was not a big house. 20 minutes with their IV pole. And when the door opened, they were too fatigued to do an eval.
Sure.
And so that really spurred my interest in cancer-related fatigue. And so I went back and studied and looked for research. This was back before I could do this all digitally. I had these big D-ring binders full of studies. And I came up with a concept for a cancer rehab program in home health. After piloting for 9 months, I realized it was an outpatient program. And then it took me a year and a half to convince my organization to let me start alone, basically in a closet, carrying in all my home health equipment. And that grew into a full comprehensive suite of allied health professionals and nursing. So it was really just sparked by a patient, in both cases, a true patient story that really had a strong impact on me and fostered my interest in this whole area.
It's crazy to imagine, but also, this is reality. It's not that far-fetched of within your lifetime, Mary, you've seen the absolute spectrum of how we manage And I would say, like, don't manage lymphedema well. I mean, amputation was the furthest from my mind, to be perfectly honest. That was shocking to me.
Yes.
But I mean, also, like, what a, you know, I'm not saying it was a good thing by any means, but what a very understandable kind of gut reaction response to this tremendous swelling that this person was experiencing. You'd be like, well, one way to not have this problem is to get rid of the problem completely. To now, in 2025, hopefully that is not happening in your area, dear listener, wherever you're listening to. We have a very different suite of options when it comes to managing our patients with lymphedema and helping them manage that. So at some point over the course of your career, you've identified, whoa, this is a big problem. How can I help? Implementing programs to helping. And then now you've arrived at Tactile, which you mentioned previously was your way of trying to help more clinicians, which that's a big driver behind our work at the cancer rehab community. Is we know we have pockets of therapists who are doing amazing work, but we want all the therapists to have access to these resources and this information and this education to be able to implement that into their communities. So can you tell us a little bit about, what you do kind of day to day in Tactile and how you are really living that mission for yourself?
I create a lot of educational content on a variety of topics, and I do that for live national webinars. I do it for personal webinars. I do a lot of in-person programs to clinicians who come to basically a dinner, and I'll present on a topic that is really driven by the sales rep in that area. So we really are trying to reach the audience and make a change in the barriers that we see to lymphedema care. So it might just be that the CLT has this tremendous wait list. Last week, somebody told me they didn't have any openings until April.
Yep, I believe that.
And a lot of the patients that we treat are rural. So they have to come a long way into the clinic. We're always playing the insurance game. Sometimes hospitals, even when you work in a hospital, they don't prioritize us or don't see us as a money-making service. And then again, our patient population sometimes just gets worn out from appointment fatigue. Sure. So we have to deal with all those things. The other thing that we have to deal with is a really shortage of lymphedema therapists. We are a rare species. And I think Lauren says that there's one CLT for every 1,000 patients diagnosed with lymphedema.
Yeah.
So we need a better equation. I don't know if we can fulfill the need in that workforce, but we need to start thinking about how we treat lymphedema differently. And what can we do to be more efficient, to get education out there, to reach the patients, to reach the clinicians, and help them understand what we're up against, really.
Absolutely. And that figure, if the listener hasn't heard that before, there's some really well quoted statistics that state, anywhere from for every 1,000 to 10,000. I think I saw a higher number just last week, but I don't remember that one off the top of my head, so I'm not going to quote it. For every 1 to 10,000 people diagnosed with lymphedema, there's one lymphedema therapist who can help them, which is, like Mary said, a tremendous gap in care and equitable access for our patients. And Tactile's working, as part of this big force to try and fulfill that gap. So for the listener who may not be familiar with Tactile, Mary, can you tell us a little bit about what Tactile is, what they do?
So Tactile is a medical device company that was founded in 1995 by a lymphedema therapist who was trying to come up with an at-home solution for her husband who had lymphedema. And that was how the lymphedema pump, the intermittent pneumatic compression device, was born. So we have several products. We have a basic pump, which is the Nimble, which is a very lightweight 2 pound, less than 2 pound device. We have the Flexi Touch, with many clinicians have heard of the Flexi Touch and used it. The beauty of the Flexi Touch is it's an advanced programmable pump. I think of it as a smart pump because we can treat any part of the body and we can make the mechanism unique, or the treatment strategy unique to each patient.
Sure.
So those are our goals are to really treat this population to spread awareness. We have approximately 1,000 employees, and this last year we treated over 90,000 patients, but we know there's way more.
Yeah, right. That's a really important point to bring up is like, yes, I mean, 90,000 is a lot. That's tremendous. There's a lot of people though. I mean, even just in the United States, a lot more who are still dealing with this and don't have appropriate
Right.
management at home. And one of the big things that I see a lot in my practice, I practice, Mary, here in Fort Worth, Texas, which is a fairly metropolitan area. It's actually, I think, the 12th largest city in the United States. However, we have a tremendous gap in lymphedema care, and a lot of people come from outside Fort Worth. In fact, very rural areas will come into Fort Worth because it's sometimes the largest city that's closest to them to where they can get that care. And so, I'm extremely privileged to live in a city, but not everybody has that kind of easy access where they can just hop on the road, go down to their friendly lymphedema therapist and get this kind of care. So can you tell us a little bit more about how the at-home treatments of the pneumatic compression device can help improve the day-to-day lives of the patients of our listeners today?
Certainly. For example, in my last position in the clinic, I worked with primarily a rural population.
Mm-hmm.
So anywhere from 1 to 4 hours, a patient would drive to come see me.
Right.
Best case, I could see them once a week.
Sure.
But I could do their evaluation. I could identify lymphedema early. I could start advocating to put them in an intermittent pneumatic compression device, the FlexiTouch, and they could see me when they could, but still be getting a good, effective systemic treatment every day. And that was how sometimes we have to modify the equation of CDT to match what happens in real life. And that's really what I think we need our clinicians to realize is that CDT, the way we learned it in our training, is wonderful. But when you think about historically how it came from Germany, and these patients were basically going to a spa-like setting and getting, MLD twice a day, bandaging twice a day, the right diet. We don't have that luxury here. We have to work with a different set of circumstances, and we really have to wrap our brain around how can we vary this equation to meet the patient's needs. And I think the home treatment of intermittent pneumatic compression is an excellent way to do it because you can start earlier and work with the patient's schedule, whether they're far away, whether they're working a lot. Many of these patients have many life roles that they have to fulfill, and it's just a real burden to also come to lymphedema therapy.
Sure. And you already mentioned, Mary, the appointment fatigue, right? Our patients in oncology are seeing on average 13 specialists at any one time during their cancer care. And that is a lot of appointments. Maybe not every week, but that is a lot to manage, like you said, on top of the other life circumstances and roles that they play. One of our speakers at the conference, Dr. Kelly Martin, talks a lot about clinical reality. And, she actually just did her CLT, I think earlier this year. And that was one of the things that she and I have had many conversations about grappling with is like, we learn the gold standard when we go and get our CLT. And that's amazing. I mean, you get this equation like you're talking about, Mary, but then marrying that to the real life of what happens, it can be really, really hard, especially as a newer therapist to kind of figure out like, how do I make that work with also accounting for, frankly, all of the other things that my patient is dealing with. And then my limitations, even as a therapist. You mentioned that best case scenario, you were seeing your patients once a week. If you've got a really full caseload, if you've got patients who are driving in from 1 to 4 hours away, that's a lot to manage at one time. And it can feel very overwhelming, I think, especially as a newer lymphedema therapist in the grand scheme of things.
I think that's true. And I think a lot of lymphedema therapists practice like a silo. They don't always work beside other lymphedema therapists. They have to problem solve and make decisions on their own. And I always say lymphedema therapy is trial and trial and trial and trial.
Where were you 8 years ago, Mary, when I needed to hear that as a new CLT?
It's still true no matter how long you've done it. So utilizing tools that are out there, we have more tools than we ever had before. We have modalities to use. We have better assessment tools. And we need to start filling up our toolbox with these ideas and not being afraid of them because we learn, quote, a gold standard that maybe doesn't fit our society and our insurance system and our lifestyle here.
Absolutely. Absolutely. And I think that really lends itself to, and I think that's a really big lesson that a lymphedema therapist learns over time in practicing. But one of the most irritating things I've ever heard, it still just grinds my gears, is this kind of attitude around oh, you'll just figure it out. It's no, sometimes you don't, because exactly like you said, Mary, I've practiced almost exclusively in silos. I've almost always been the only clinician on site wherever I've worked. And, now I've been practicing for a few years. I feel like I can do that confidently. But early on, it was very, very challenging to do that. And to not have that luxury of other clinicians who are practicing in lymphedema, who have been doing this, who are, really have a grasp on how to best manage this very, very complex, layered condition on top of this very dynamic, layered patient population. That is such a privilege to have, and not everybody has that. And so I think that learning process can sometimes be very hard for newer clinicians. What are some maybe misconceptions or myths that clinicians may have or develop as a part of all of this that we're talking about around managing lymphedema?
I think one of the biggest ones that we see today is that breast swelling only happens in the arm. And now, because of improved surgeries, improved treatments, I can tell you in the last 5 years of my clinical practice, I really didn't bandage arms. I was dealing with breast, trunk, axillary, back swelling. And so, and the other thing is that you have to realize is that the EMRs, they have a place to put in your measurements for limbs, but they don't always have a place to document the trunk symptoms. The other misconception is that all lymphedema is swelling. That's not true either. It's skin changes. So we see scarring, fibrosis. Both of those can impact the lymphatic system, whether you can see or feel swelling. But patients will report significant symptoms. They'll have pain. They'll have trouble sleeping. They'll have trouble reaching. Just a whole host of symptoms that they'll report to you. So we really need to recognize and still diagnose that as lymphedema. And that's a common misconception that I think is still very much out there. And we do have studies that show us that patients who have breast symptoms actually have lymphatic pooling in the region, and that they collateralize differently than how we learn to do MLD. So I think that, that has really, in the world of tactile, that type of research with ICG imaging, plus listening to what our clinicians tell us, plus listening to what our patients tell us, has really led to some design changes in our garments, which I think is great. Because what does the breast patient tell you when they come in now? They say, "This is driving me crazy."
Yeah.
That's what they say.
Yeah.
So, we really felt that, this is very different than my early childhood patient, right? This is the progression of what we've seen just with improved treatments. And we really needed to update our pump garment to address that need, which we did.
It's interesting you bring that up. I mean, again, as a clinician, I feel like the majority of my patients right now are dealing with this truncal, axillary, and I've seen a lot of back swelling these days. And I think culturally, this is my perspective. I'd love your input on it, Mary. Culturally, we're doing a pretty good job. We're doing all right at educating people on lymphedema from the arm perspective. If your arm starts to swell up, it's lymphedema, right? And I think there's more of an appreciation and an understanding of that, which is great. it's great that we're getting there, but we're not seeing that same level of awareness and education around the truncal side of swelling. And I agree with you. Like, I have a patient right now. I mean, we are just like fighting the swelling kind of right superior and lateral to her breast tissue right as we get into that axilla area. That's the most problematic part for her. We're doing a great job of managing her arm swelling. She does wonderful wearing her compression for the arm and whatnot. But it's really that pesky axillary and truncal swelling that can be so much more of a challenge. And I think a big part of it stems from not everybody knows to look for that. And therefore, we're not catching it as early as maybe as what we would have if it were just arm swelling. But I would love your input on that, Mary.
Well, I think we need to think about how we assess it. So we definitely can take circumferential measurements at the axillary line. We should also take them at the nipple line, or what was the nipple line. And maybe that patient has a breast, one that's high and one that's low now, right? Or one that's totally fibrosed and one that's not.
Right.
And I think you need to decide how you're going to measure that in a repeatable way. So,
Yes.
and that may be unique, and that may not be an EMR circumference, right? So you have to decide, use your clinical knowledge. How am I going to measure progress in this patient? Then you want to look at tissue mobility. You want to look at skin adhesions. You want to look for cording. You want to look for discoloration, tissue thickening, all the textural changes that we can see in these patients, and document those well, and understand that all of those are a diagnosis of lymphedema, not just swelling.
Absolutely.
And we need that kind of information to, the pump is a great tool for these patients because we've updated our garment to include an axillary strap that inflates and treats the area.
Nice.
And the beauty of that is they can get very focused treatment there, but we can also add in some type of chipped foam padding, or, there's so many products that we could put underneath the pump to really treat fibrotic areas. So I think that really thinking a little more creatively about how you approach this is what we need to do. And then also a good symptom screener tool of some kind. Is a useful tool. So, if you use some of the validated tools that are out there, the LLIS, other ones, the DASH, those are limb tests. We don't have a tool for the chest and breast. And that, I think, is something that's lacking in the research, because we are seeing that, but we don't have a way to measure it. And that would drive a change in what we see in our EMRs about how to document it.
Sure. Okay, I'm picking up on a lot of useful tidbits that you're putting down here over many, many years of practice and refining this process for you. And I think that an early clinician might be missing some of these things. So you've talked about how Tactile has adjusted some of the garment and like that, again, like we said, to specifically target this axillary area here. You also mentioned using chip foam. What are some other of these tips and tricks that either you have used or you've heard of clinicians using with tactile pumps to really get like super targeted, super focused on patient impairments?
Well, you can adjust pressures if you want to, but I always thought about it as what I do with my MLD. Do I necessarily increase pressure or do I increase duration? So I may work longer in an area to promote a change in the tissue. And typically I would do MLD until I could palpate a change or sense a change or feel a temperature change, or somehow the skin was moving better. A really great tool to assess skin mobility and adhesions is the adherometer. I don't know if you're familiar with that, but it is a great tool to utilize just to measure in millimeters how far tissue is in a parallel plane moving, which can really impact function. So really, drilling down into new tools that are out there for us to use. And a lot of people have a laser. A lot of people might have a Hyvamat. We have negative pressure devices. All of those can be useful for this axillary breast chest symptom that we see. But then following up with the pump with some type of pad underneath or altering the settings somehow. Because in a truly fibrotic person, you may have to increase pressure. I know even in our hands-on, we may increase pressure, but we may do more of a static hold until we can sense a change in tissue, and then move on to a next site. So we've learned so much about how to address difficult symptoms in the trunk.
That's so exciting. I mean, again, like you've seen such a change over the past few years of how we really are managing lymphedema. And I mean, even in the past 8 years that I've been practicing, it's been exciting to learn more about these tools and techniques and whatnot that are really, again, marrying that. We know that this is gold standard for a reason. How do we make that work within some of the restrictions and just the facts of, frankly, American healthcare that we're dealing with these days? When it comes to, so the clinician who is listening saying, okay, I get it. How do I actually bring this into my practice? Like, how do I get the patient who's sitting in front of me a pneumatic compression device at this point?
Okay, well, in my clinical practice, I would evaluate on day one. I would educate them about the pump, hand them literature about the pump, and really explain to them why I see this as a viable home program, because they can't come to me forever. They can get an hour of treatment a day that is clinically proven, tested through various research studies to do what it says it does, which is to remove that stagnated protein in the tissue. And I would set the stage for them. So I was a social worker first, so I'm all about providing education and resources.
Yes.
So I introduce it on day one. Day two or day three, after that eval, I've already contacted my sales rep and said, this is the patient. This is the clinical presentation. They definitely have lymphedema, and I try to make that second or third visit a pump demo in the clinic.
Nice.
They can be done in the home. I like them in the clinic because I like the back and forth with my sales rep, because they will know what that patient's specific insurance criteria is. So I may be documenting all kinds of things and not thinking about the elephant in the room, right? Because the patient has presented with whatever social emotional response they're having that day. But the sales rep can say, well, we need to have this, just to substantiate the need for the pump with this particular insurance. So once that is done, Tactile takes the lead after that. So they will make sure insurance criteria is met. They will process the order. The patient will accept the order. And once the device is at their house, a trainer will come to their house, open the box for them, unbox, set up the pump, and problem solve any fitting. Explain to them once it's fitted, all they do is unzip it like a jacket, or unzip even the leg piece. So there's zippers, but there's Velcro to contour to that patient's body. But I really like the service from beginning to end. I liked that as a clinician very much. And it really made me a loyal follower, because I wanted my patients to be treated at home the way I treated them in the clinic.
Ooh, I can definitely get behind that. What are you've explained the process behind how to go from getting pump, thinking of this patient needs pump to getting the pump in the house. What are maybe some things that the clinician needs to be aware of to facilitate that process? Because as we know, there's documentation requirements. We know the big elephant in the room is insurance, which I know one of the things that I'm working with my patients a lot is to make sure, just having a conversation on where are you at as far as your deductible, your out of pocket, just so I know, and then can kind of, again, facilitate that conversation among these three parties to make sure that the patient feels really good about, okay, I understand what this does. Financially, I also understand what's happening, so that I can get this pump in my house to help me with my at-home management.
So you explain what you want me to. That was a lot.
Yeah, that was a lot. So what does the therapist need to know on our end from an admin or documentation perspective to facilitate getting the pump to the patient's house?
Okay, we need measurements. So then we need at least two sets, what I mentioned, axillary measurements at the nipple line, and then two unique characteristics. So that can be fibrosis and scarring. That can be a cord. That can be, any of the terms we learned like hyperpigmentation, hyperkeratosis. But in the case where today we're kind of focusing on breast, so I would say fibrosis and scarring, simple. Tissue thickening, tissue texture changes. Unique characteristics need to be in there. And then just following the steps of getting the pump. So, and they absolutely have to have a lymphedema diagnosis. And this is where some therapists get hung up because they see fibrosis, but they don't think that's lymphedema. But it is.
Yes.
So really driving home that they need to recognize all those skin changes as a component of lymphedema.
For the clinician who's interested in learning more about this and making sure that, again, we're facilitating this process as much as possible, how does Tactile support and educate clinicians on this and other information that's really helpful?
So many ways. So we have, if they go to tactilemedical.com and click under clinician and look at education, we have a whole knowledge center. Those are free continuing education modules that are there for them. We have recorded KOL webinars that we've done. My team, we do national webinars on a monthly basis. So soon we will be having an upcoming advanced breast cancer lymphedema webinar coming up. I'll be doing one on fibrosis. I'll be doing one on advanced head and neck cancer. So those are available. They're usually presented twice a day, once over the noon hour, once in the evening, and those are free CEUs. So we do that in a lot of ways. But the other thing that our clinicians have asked for is more literature that they can access themselves or share with patients. So we do have a new breast cancer related lymphedema monograph, and we have a flip book. And those are ways that therapists could use as education. The other thing that I do like is we have an app. It's called the Calys app. And the Calys app has wonderful educational modules that aren't Dr. Google. They're well-vetted information for patients. The patient can troubleshoot if they have a pump. If their pump's on order, they can track the progress of their order. If they want to have an activity report to print and present to their provider or their therapist, they can do that. So it's just a really user-friendly app that helps further lymphedema awareness with our patients, as well as, clinicians.
Yeah, absolutely. So we kind of addressed this, but just in case people are looking for this and more, what resources or tips would you offer to the listener who wants to feel more confident in treating a person with lymphedema?
Well, I would say participate in educational events. I would follow, there's various people like you, at least, that they should follow, because there's a wealth of information in what you do. And that wasn't available when I first started. We can do one-on-one clinical troubleshooting. So we have an external team, and we handle just out-of-the-box questions that come in. Can you use the pump with this? Or how do I modify the pump to do something that they want to do? But if it's on a current patient, we have an internal clinical specialist team who are all CLTs. So those therapists help patients who already have their pump and are experiencing problems. So that ongoing education is great. The other thing that I like to do is I like to go visit clinics. When I'm going out of town to present a program, I like to go visit clinics, or I like to shadow for a day. I love a lineup of complex patients. because it gets my juices flowing again,
Sure.
and it reminds me of what I do like about patient care. And sometimes that's really helpful because our clinicians do practice like silos, and to have somebody come in who maybe has done a few things or has a few more ideas, I think that's a great way to spread knowledge and skills.
Now, we teased this at the top, but I'd love to get into a little more. Are there any recent advancements or research findings in the lymphedema treatment space that you're particularly excited about?
Well, I am excited, and you probably gathered this. I'm very excited that they changed the Flexi Touch vest design.
Yeah.
And that was really based on a study by Hayden and White and Suami, where they did ICG imaging on healthy patients and on patients who had breast conservative treatment. And they were looking at using the ICG to determine where there was lymphatic pooling and how did that pooling try to collateralize. And what they found was, that it collateralizes to the peristernal, to the contralateral axilla somewhat, to the intercostal lymph nodes, and to the clavicular. So that really led to how we designed from a unilateral vest to a bilateral vest. And it really has been effective, and patients tell us how much better it is. So I think that's exciting. And I do think that was a nice advancement for us. I do think there's a number of new ICG imaging studies that have come out that not only are going to influence our garments, but they're going to influence how we as clinicians do our hands-on care. Absolutely. Or how we select the pump to work, because the pump can work in various directions. And sometimes, we've learned one way for that fluid to go, but we don't, as we're looking at a patient, really understand what's happened. How has that patient collateralized? And sometimes if the pump just isn't working, change the direction. I've done that with my hands. I've done MLD kind of just like on a gut instinct, right? And I think it's because what we do is science, but it's also art. Sometimes it's just a sense of knowing, where does this need to go? You're looking at the patient, you're listening to what they're telling you, and you're like, I think I'm going to drain it this way today and see what happens. And I think that's valid. I don't think you're going to hurt anything trialing those things.
Again, I think especially in cancer rehab, there's such a marriage of science and art behind it. And I think lymphedema is especially one of those areas, which again, I keep coming back to this. I think this is just my phrase of the year, Mary, is the clinical reality. A few months ago, I had a patient who, kind of same thing. We were doing MLD and I was doing it how I usually do it. And I was like, you know what? Let me try a different way just to see. And it did not work. Like the patient came back the next time and was like, don't do that again. I absolutely puffed up. I was like, noted. But we have to try things if we're going to figure out what's going to work, what's not. And it's really exciting to see. I think we're really stepping into the age of ICG green and seeing what are we learning? What are we seeing beneath the skin that we didn't know previously? And how does that inform our care? So lots of exciting things on the horizon, I think, for lymphedema treatment advancements.
Well, the other thing that imaging has shown us is that there are really morphological changes in the endothelial cells. So as that inflammation persists, those overlapping endothelial cells in the capillaries get gooey, they get sticky.
Sure.
And then the collectors get leaky. So it really explains, you used to always hear the term, stage 2 is irreversible. And I'm like, why? Well, it's because there really are morphological, physiological changes in the vessels. So knowing that really gives you a reason to intervene early. Don't let it get that far. It's okay to intervene stage 0, stage 1. In fact, that's where we should be intervening to really prevent these long-term problems. And you don't need your patient to become a frequent flyer in your clinic. There are more than enough patients to go around for all of us to be busy forever. So I think not feeling threatened by using newer modalities and tools such as the pump to really provide another way to give effective treatment that really gives the patient quality of life and a good reduction of symptoms.
Love that. Mary, for the listener who is like, I need more information, I need to learn more about this, what is the best way for them to connect with Tactile Medical?
They should go to tactilemedical.com. There is a button that says connect us. And if they fill out that information, someone will contact them and identify who their sales rep is, who can come in and do all kinds of in-services. They may connect them with me at some point to keep that education ongoing and help them troubleshoot the really complex scenarios that they deal with.
Very nice. Mary, thank you so much for coming on the OncoPT podcast to talk about this. We are so excited to get to share this with our listeners. We are also tremendously excited that Tactile is helping to make the Cancer Rehab Community Conference 2025 a reality, and we cannot wait to see you and some of your team at the conference. I know that some of y'all will be there, so we're very excited. Is there anything else that you'd like to leave my listeners with today?
Don't be afraid to change your paradigm. Don't be afraid to accept new ideas or even challenge them. Don't be afraid of that, because that's how we all progress, and that's how we're going to do a better job of treating lymphedema.
I love that. Well, Mary, thank you so much for coming on the podcast again. We cannot wait to see you at the conference, and we cannot wait for you listeners to see Tactile supporting us at the conference. So thank you so much. And until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.